Welcome to the EMT Pro podcast, where we deliver relevant EMS content from the field and the classroom each week. Each episode of this podcast can get you 1 full hour of CE through our partner, emt-ce.com, so head over there for more information. So welcome to the podcast. I'm your host, Steve Williams, and with me as usual is Dan and Holly. Guys, say hi.
How are you?
Hey, Steve.
Good. I'm doing well. Thank you for asking. We've got a fun episode. We're actually going to be talking to one of your coworkers.
Mm-hmm.
Her name is Kari.
Kari's
and
she's she is
a respiratory therapist.
Respiratory therapist, paramedic out of our Washington area.
Cool. And she's a vent pro.
She's a vent master.
Ventilator expert.
Yes.
Is there a certification behind that, or is it just I've gone to so many dang classes and I'm the SME?
Yeah. It's an actual, like if you go to paramedic school, you go to RT school, nursing school. Yeah.
Cool. So she's like certified in this.
She's legit.
She's legit. Yeah. Okay. Awesome. Well, we're going to get her on the phone, and I'm going to let you guys kind of lead this one and ask questions. And
okay.
I'll be here, but I want you guys to, since you guys kind of know her a little bit better, let's talk to her, see what she knows, and we're going to go over and see what we can learn.
All right. Sounds good.
Cool.
Hello.
Hi, Kari. How are you?
I am well. How are you?
I'm well. I'm here with Holly, and I'm here with Steve Williams.
Hey, Kari.
Hey, Kari. How's it going?
Doing great. Thanks.
So as you know, today we're going to go over mechanical ventilation, just some of the basic stuff, working our way up to some not so basic stuff. Just trying to get your expertise, because this is one of those things where, I really didn't know this. When I first started, we had that auto vent.
Oh, yeah.
Set
it and
I've
forget
used
it.
that before.
That was amazing.
Yeah.
And
yes.
But it was just a tool. I never knew that the ventilator is actually a treatment. And so that's what I want to get out of you today, is how we can use that as a tool for treatment.
Sounds good.
Yeah, I think like our med bag, I kind of view that as my toolbox. Like there's lots of meds in there that do different things.
Mm-hmm.
And maybe we can just get in the vent toolbox. Like I've
like
got the
it.
patient that's presenting
yeah.
this way. What are the different things that I have in my toolbox to help out?
I like it.
Perfect.
I love it.
All right, so let's just start with the different modes of mechanical ventilation and just a brief explanation of what they are.
I can start there. If you guys don't mind, I'm going to just jump ahead just before we get into modes. I always, when I teach these sort of classes, I always teach to look at the ET tube first, because that's where all of this happens, right? This is where it all begins. So you always need to assess the size of the ET tube and the depth, because if you don't have the right size or the right depth of the ET tube, no matter what magic you can do with your ventilator, it may not be enough. So I can't emphasize that enough, especially in pediatric patients, is to always make sure you have the right size ET tube at the right depth, and listen to your patient before you start in on the ventilator part.
So how do I know my tube's the right size?
That is an excellent question. So there are different formulas that you can use. I use 16 plus the age divided by 4. And that is for an uncuffed tube. You can minus a half for a cuffed tube. And there's
I
also
went my entire career almost not knowing that was for a cuffed tube.
Yeah, me either.
Yeah, right. And a lot of people don't know that. And there's also a formula for ET tube depth, which is for 5 feet and taller, which is the height in inches divided by 4 plus 4. And that will give you an average approximation of your depth of ET tube. Because I think we all have learned, adult female patients get a 7.0 tube at 21 centimeters, and adult males get an 8.0 tube at 23 centimeters. But it really depends on how their height, right?
Mm-hmm.
So the shorter the patient, you're probably not going to have to put the tube as deep. And a taller patient, you might have to put it deeper than you would think.
So can you repeat that equation there again? The height?
Oh, height in inches divided by 4 plus 4 will give you a good approximation of the depth of the ET tube.
All right, so let me think for a second. So 72 inches is 6 feet.
I'm 75.
Easy math.
What's that?
I'm 75.
Okay.
Oh,
so
wait,
we'll
but
go
72 is easier
Okay.
to divide by 4, right?
So 72 divided by 4 Okay. Someone who
18.
went to college. Okay, 18.
Oh,
Yeah.
somebody needs a calculator. Okay.
Yeah.
We have a 5-star medic here. It's fine.
Okay. So we're at 18.
We're covered. Yeah.
Plus 4 is 22?
Plus 4.
8.
That's correct.
Right. You divide by 4 and add 4.
That's
And
amazing.
it's 22, right?
It's 22.
Yeah.
Oh.
Yeah.
So Dan, you're
I'm 4'2".
4 foot. So
Don't put it very deep.
8-0 tube for you.
Right.
All right. Okay. That's an excellent way to think about that. I'll have to
And
work on that
I
a little
think
bit.
a good rule of thumb still for pediatric patients, since that formula is only for 5 feet and taller, is 3 times the size of the tube is a good estimate
For
on the
5
depth.
feet and under. Okay.
That's correct. Yeah.
So for Dan and anyone else.
the special formula.
Okay. Let's move on.
All righty, moving on.
Awesome. I love this. This is like the
Yeah.
RT brain and their
Right.
process, like how to
I
go
like
down the
that a lot.
checklist. Okay. So check the tube size, check the depth. Now what?
Hey, can I
Okay,
ask you a quick, Kari, can I ask you a quick question? Let's say
absolutely.
it is a little bit deep. It's still not, right main stem or anything, but what is that going to do with the ventilator how is that going to affect the ventilation?
Well, if it depends. It could be deep enough to where you're not getting equal tidal volume to each lung. So it can affect your ventilation and oxygenation. It can make a huge difference, really,
Okay.
if it's a little too deep.
Okay.
And especially the smaller the patient, the more that's going to be emphasized, the more difference you might see, just because, smaller anatomy
Right.
and less room.
All right. I like it. Thank you. All right. Moving on.
So moving on.
Cool.
So Holly, I think you asked about ventilator modes. Is that correct?
I did, but if you
Yes.
have a process
Yeah,
that
if
you
you
go
have a
through every
process.
time, take us through it.
Yeah.
I'm interested.
No, that's good. Well, so my process is, number 1, always check the ET tube in depth, listen to your patient. And then number 2, when they're on the vent, you need to find out why they were intubated. What's the disease process? Were they intubated because it's a respiratory issue, respiratory failure? Are they intubated just for airway control? Are they intubated for pain control? So you have to kind of think, what's the disease process or the reason why they were intubated? And that'll give you a good idea of what you can expect for ventilation and oxygenation. Because if your patient is intubated for non-respiratory reasons, they should be very easy to ventilate.
Mm-hmm.
Let's say they're intubated for seizures, intubated for a head injury, meaning no lung injury. Then those patients I would expect to be very easy to ventilate with low oxygen needs.
That is true.
So
Okay.
So it kind of gives you an idea that you shouldn't need a lot of big settings for those kind of patients. So for patients that are intubated due to respiratory issues such as ARDS or pneumonia, those are the patients where I would think, okay, this is going to be a lot tougher. I'm going to have ventilation, oxygenation issues, and what can I do to fix that?
That's when you're really using it as treatment as opposed to a tool.
Exactly.
Okay.
Exactly.
Okay.
Yeah. And then the next thing I think of is this a ventilation issue? Is this an oxygenation issue, or is it a little of both? And then you can start your process from there. So if it's a ventilation issue, a good thing to remember is ventilation is always fixed directly with alterations in your tidal volume and or your respiratory rate. If it's an oxygenation issue, you can fix that with your FiO2, which is very easy, and your PEEP. So those are directly proportional to your oxygenation.
Okay. Excellent.
Kari, do you have your typical adult patient that's going to be intubated? Do you have a go-to PEEP setting? I've heard some different numbers there. I'm curious what yours are, if you have one.
Yeah, that's a great question. All patients, pediatric to adult, actually infant to adult, even our neonates,
Mm-hmm.
they always get a minimum PEEP of 5. Always.
Okay.
Always. That helps stent open the lungs. Because what we want to do is prevent that cyclical opening and closing. So that helps stent the lungs open and makes it easier for the patient to oxygenate.
Mm-hmm.
So
how
minimum
long can they
of
have PEEP
of
though?
5.
Like if you have a patient who's intubated for a significant amount of time, is PEEP always applied, or is it something that they're gonna mess with?
Always applied.
Okay.
Yeah, good question. Always applied. And again, a minimum of 5. Now, if you have an obese patient, I suggest a minimum of 10, just because the pressure of or the weight of the chest, that helps. That PEEP of 10 opposes that weight on the chest.
Gotcha.
So it helps keep those lungs open.
So us just sitting here in this room, we have a PEEP of 5 naturally.
Right.
So if you've intubated your patient, you still want to give them some PEEP because
Right.
I got PEEP, you got PEEP.
Everybody's got
Everybody
We all
got
have PEEP.
We got
Exactly.
Nice.
We all have PEEP. Exactly. We got to keep the PEEP going. Yes.
So what about the obstructive patient, the COPD asthma patient, who already has a lot of their own auto PEEP? Or what is your thought on that? Still 5 a PEEP?
Yeah, that's a good question. There's been a lot of controversy in the literature about that, but I think the latest studies have shown that a PEEP of 5 will not be detrimental to that patient. Most of these patients that are intubated due to COPD or asthma, they are very well sedated, if not paralyzed. So they're not triggering the vent. And that will create, if they're not triggering or fighting the vent, that will decrease any incidence of auto PEEP. So I think a PEEP of 5 is absolutely safe, even for COPD and asthma patients.
Okay. Good to know. All right. So moving on.
Moving on. So we can go to tidal volume. So always, tidal volume, 6 to 8 mils per kilo ideal body weight. Ideal body weight is what I want to emphasize on that. Not their normal weight, but ideal body weight.
So you're saying if I weigh 400 pounds, my lungs didn't magically get bigger?
Exactly. Exactly. I wish I could be my ideal body weight, but
have you seen that chart?
So,
holy cow! If you want to feel bad about yourself,
right?
Look at the ideal body
I
weight
know.
chart.
I'm pulling it up right now. I'm trying to find a good one.
And what country is this
Exactly.
ideal?
Yeah, not America, that's for sure.
Right?
So, Kari, 6 to 8 mils per kilo is your target. What if we go down to like 4 mils per kilo?
Well, you can do that. The only time I would suggest that is with an ARDS patient. And the reason for that is because we really want to diminish. I talked about that cyclic opening and closing of the lungs. With ARDS, we want small tidal volumes to decrease that opening and closing. And that's why we need higher respiratory rates to maintain that minute volume.
So what about if, and you may cover this later, but let's say we have a lung injury patient and the P-plats are significantly high, and we start tailoring down the tidal volume. Can we go to 4 even though they're not ARDS patients, or should we put them on pressure? Am I getting way ahead of us? I think we're getting way ahead of myself. All these questions I want to answer.
I like the question though.
I think, yeah, no, it's a really good question. If it's not an ARDS patient, it is not recommended to go below the 6 mils per kilo ideal body weight, because that can create lung injury as well. So remember, ARDS patients have to have bilateral infiltrates, not cardiac in origin. And if it's not an ARDS patient, say it's just a pneumonia where you just have injury on the, one lung, you can actually injure the lung if you don't give enough volume.
Oh.
So the lower lung volumes of 4 to 5 mils per kilo ideal body weight is only recommended for ARDS. That's actually a really good question.
Okay.
So what is the normal minute volume for adults? Anybody know?
60
5 to 6 liters?
60 cc's per kilogram per minute. That's for you and I right now, right?
Yeah, but if we're intubated.
Oh, 120. Are we recording right
Yeah,
Yeah,
right.
we are.
We
You're
are.
doing
now? Did you see
It's
my
that-
fist bump right there?
I
It's
did.
that awkward.
Woo-hoo!
It's that awkward silence.
Right.
Good. So yeah. So it's basically 6 to 8 liters per minute,
Right.
right?
And so
Which
my 120
Yeah.
was correct, right?
yeah. Well, good, sort of. Yeah.
Wow.
I guess it depends on what your kilo is, right?
Right. So 120 per
Yeah.
kilo per minute.
Yeah.
Okay.
And that's, yeah, right, correct. Yeah, for intubated patients. Good. So I think that's really good to remember. So you have to remember what the normal respiratory rates are for each, for an adult and for peds, which peds can vary quite a lot, right? Because there's such a huge age range with those. So minute volume is tidal volume times respiratory rate. And the ventilator is great because it does a running actual
Calculation for you.
Thank you. Calculation for you on the vent. So it'll always show you your updated minute volume. And that includes that the patient is spontaneously breathing over the set respiratory rate as well.
Nice.
It's so the 120 or the 6 to 8 that you talked about, that makes up for dead space, right? Your anatomical and your mechanical dead space.
In
That's
adults,
why it's increased,
probably,
right?
But
Yes, it does.
Okay.
It does. But you can have, so one thing between tidal volume and respiratory rate, with respiratory rate, there's dead space associated with every breath, right? Because there's dead space, like the part that doesn't participate in gas exchange, like our upper airway.
Right.
The part where the ventilator from the T to the ET tube, that does not participate in gas exchange. So every breath, you'll have a little bit of dead space. Now with tidal volume, there's no dead space associated with tidal volume. So one thing to consider when you're going up on your respiratory rate, you'll always have a little bit of dead space with that respiratory rate, even as you go up, if that makes sense.
it does.
So
So your
sometimes
tidal volume is breathe in, breathe out. That's your tidal volume, right?
Right.
Minute volume
you
is
can-
the amount of volume you're breathing in and out over a minute,
Right.
right?
Correct. So with tidal volume, you can sometimes, if you stay within the 6 to 8 mils per kilo, you can get a more effective clearance of CO2 if you titrate that versus a respiratory rate.
So you would prefer to get that minute volume via the tidal volume as opposed to respiratory rate? Is that what you're saying, to get clearance?
Yeah, I titrate the tidal volume. If I'm trying to decrease my CO2, I try to titrate my tidal volume first to an acceptable level, keep it between 6 and 8. And then if I can't titrate it up anymore, say I'm maxed out at 8 mils per kilo, then I'll titrate my respiratory rate.
Awesome. So let's say you've got a patient that you're trying to change the CO2, and you're titrating your tidal volume first. How long are you waiting between titrations? I mean, are you waiting 2 minutes, 5 minutes, 10 minutes till you see a change?
Usually about 5 minutes. Usually
Which
you can
could be
see
an
the
entire
change
transport
pretty-
for us.
Right. Exactly.
Totally.
So be patient is what you're saying. Titrate one thing at a time and be patient.
Yeah, and that is a really good point, is to titrate one thing at a time, because if you change your tidal volume and your respiratory rate at the same time, you're not really sure what worked.
Right.
And there is no right or wrong. You can absolutely titrate a respiratory rate first if you don't want to titrate the volume. Just understand, if you're not able to meet your CO2 goal, it could be the dead space issue as you're increasing your respiratory rate, and then think about increasing your tidal volume if the rate doesn't work for you right away.
So can I get back to dead space real quick? So anatomical
Sure.
dead space is like the trachea, the bronchioles, anywhere in the body where there's no gas exchange. Is that correct?
That is correct.
And the mechanical is the ET tube, the vent circuit, the HME, all that kind of stuff. That's what mechanical dead space is.
Absolutely. I'm glad you brought up the HME, because that can be a lot of dead space.
Dan is so excited that he's getting all these right
Isn't
right
it?
now.
excited.
Yeah.
Right?
He's loving this.
Especially for pediatrics, if their
Right.
tidal volume 60, half of that could be mechanical dead space. So you're only
Absolutely.
ventilating them at 30.
Absolutely. The smaller the patient, the more that HME dead space will affect that patient. So the smaller the tidal volume, even if you have an adult patient, so you have a normal sized adult patient, but say it's ARDS, so you're ventilating at very, very low tidal volumes, let's say 4 mils per kilo, that HME could make all the difference in the world. And you may not be able to ventilate them due to that dead space. So what do?
Increase the tidal volume.
Increase tidal volume?
Increase the tidal volume, yes. So what you're looking for, what you want to look at is your exhaled tidal volume number. So you can increase your tidal volume. You might be over 8 mils per kilo, but as long as your exhaled tidal volume stays between 6 and 8, you are good.
So when are you saying, so are you talking just kids right now, or are you talking everyone?
Everyone.
Okay, and so to get that exhale tidal volume, they need to be in pressure mode, right? On
Either one. You can be in pressure or in volume.
So you're talking about the calculation that's at the top all the time, as opposed to the exhale tidal volume?
Mm-hmm. The VTE.
Yeah, VTE. That's there all the time? Oh,
Yeah, it's there all the, yeah, you have to wait for it because
It scrolls
scroll
through. For, yeah.
It does.
Okay.
So yeah, it scrolls through maybe about 7 or 8 different parameters, but it does. Yeah, it is there every time.
So let's recap.
And that's something that
Go ahead.
it's something that's nice because when it does scroll through, you can hit the select button, and then it'll hold that value up there. So if that's all you want to look at, you can keep it up there.
Wow.
So you can just see the exhale tidal volume.
Okay.
So when it scrolls through, hit select, it should stop. And then you can see your exhale tidal volumes all the time.
Okay. Got it.
Because really what you want to know is what you put in should be pretty much what you get out. Right? If you're in volume control,
Right.
what you put in should be what comes out.
Okay. I'm a little
So what if you
confused,
put
but
in
okay.
450 and you're getting out 500? What's going on?
Sometimes that could just be from patient effort, especially if they are triggering the vent. It could just be their own support that's added to that. Usually it's about the same or maybe 50 mLs less is pretty normal. But if it's over what you're giving them, usually it's because they're participating.
Okay.
And sometimes if you do have an exhale tidal volume that's a lot higher, sometimes that can be a signal that they need a higher tidal volume to make them more comfortable. So you also have to look at how they're tolerating the settings.
Yeah, and that can also cause barotrauma too, right? Like if you're not giving your patient enough support and they are working against the vent, you're creating some barotrauma there as well.
Absolutely. That asynchrony can be very injurious to them because if they're trying really hard to take a breath and the ventilator isn't giving it to them at the right time, that can create a lot of barotrauma for sure.
And fixing that, we either need to give them more volume or pressure or pain and sedation.
Pain and sedation.
Well,
I think
we'll talk a lot about that today because I feel like we could be better at sedating and using pain management for our intubated patients.
Yeah, I totally agree. They deserve, if that were me, I would want the
All
whole
of it.
bag, right?
Yes.
I don't want to remember that.
No.
Right. They deserve to be very comfortable and not remember that incident for sure.
Well, let's recap what you were
Another
saying about coming into the room. You're going to find tube size and depth. You're going to figure out why they got intubated. And from there, we're figuring out what the settings are on the vent.
Right. Figure it out and then see how they're doing on their vent, right? Because I know when I do it, something always goes wrong, right? There's my numbers were great, and then I put them on our vent, and then it's like, oh, geez, this is horrible.
Right. And it's good to look at what they're on. If they're on a vent, before you get there, I'm a big fan of if it's not broken, don't fix it, right?
Right.
I will look and see what they have number one thing I'll look at is that tidal volume within 6 to 8 mils per kilo ideal body weight, because we have to keep that, because our number one goal is to do no harm, right?
Right.
The goal of mechanical ventilation is to not further injure the lungs.
Okay.
Right? Because once we introduce that tube and put positive pressure down there, it just sets the lungs up for more injury. So our goal really is to prevent further injury.
Mm-hmm.
So I will make sure the tidal volume is within the 6 to 8 mils per kilo. I'll look at the respiratory rate to see if it makes sense with the disease process. If this is a patient that has a metabolic acidosis, say has a severe lactic acidosis from sepsis, this is a patient where I'd automatically think they need a higher than normal respiratory rate, right, to make up for that acidosis.
Right.
That doesn't mean you have to set the rate to 30, but you do need to set it higher than normal. So I would say you could start like in the mid 20s, 24 to 26. And then when you get time, if you get time to look at any, we usually don't get a lot of ABGs, but if you can look at a chem panel and look at their CO2, that can give you a good idea of where their acidosis is.
Right. It's good. The history, are they DKA? Did they overdose on aspirin? What?
Exactly. And if it is a DKA or aspirin overdose, those are the patients that really need the, double your normal minute ventilation, right? Because if you come across a patient that's intubated for DKA or aspirin overdose and you put them on normal vent settings, like a rate of 12, a rate of 16, that could kill the patient, right? Because all that's going to do is decrease that pH even further, and they're going to get more acidotic. So, yeah, super important to know that and to maintain that minute ventilation for sure.
Yeah, because naturally their body's trying to blow off that CO2, which is the acid. And if you're retaining all that acid, now their pH just went from 7.2 to 6.9.
Yeah.
And it can happen pretty quickly. And so it's important, I think, in those cases to maybe ask what was their respiratory rate before they were intubated.
Right.
Or like Kari said, get the chem panel and calculate a Winter's formula and maybe try to figure out where that CO2, the CO2 might need to be 20 or 24.
Right. Or if you're doing the intubation, do a mental note of what.
Yeah.
Why
Those are really tricky
so.
patients. I'm glad you brought that up, Kari.
Yeah, those are tricky patients. And it is really good to know what they were breathing before, what the history is. And if I look at the chem panel, I love the chem panel because the CO2, if the CO2 is 15, I know, okay, higher respiratory rate. That's all I clue in on, right?
It's so easy to chase the numbers, though, and want to make it look pretty. But these specific patients, we really need to be outside of our comfort zone.
So you're
what it comes down to, is these acidotic patients, metabolic acidosis, need high rates, right, to prevent further worsening of their pH status. Obstructive patients need low rates, right, to prevent auto PEEP.
Okay.
And give enough time for escalation.
And so I'd like to get in that in a little bit, the IDE and all that stuff. First, could we go over just a quick rundown difference between AC and SIMV and when you would use either one of those?
Absolutely. So AC is assist control. It's not a true control mode. But what it does is it will give the patient the set volume or the set pressure, whichever one you want to use. It's available in pressure and volume. If you have an assist control set of a rate of 16, it'll give that patient 16 breaths for the minute. If the patient breathes spontaneously in that minute, it will give that same amount of volume or pressure when they trigger the vent, if that makes sense.
Yes.
Yep.
So that's where you stack the breaths. Is that correct?
Yeah, you can, especially if you have a patient that has a strong respiratory drive on top of their set ventilator rate, they can absolutely start stacking breaths because each time they trigger, they'll get that set volume or that set pressure every single time. Whereas in SIMV, which stands for synchronous, intermittent, mandatory ventilation. So the synchronous means that when the patient triggers the vent, they get a breath. The mandatory part of that means that they get the minimum that you set. So if you set an SIMB of 16, they'll get a minimum of 16 breaths. But the difference is when they take a breath or when they trigger the vent, it is all, they decide what the volume is, what the pressure is, when the breath cycles off. It's all on them. So the ventilator doesn't help them besides the pressure support that's given.
And when you're using SIMV, always give them pressure support, which it automatically dials it in. So it's nice for us.
It does. The vent is very smart and it automatically lights up. So it clues us into, hey, make sure you set this. And it does, I think it defaults to a pretty appropriate pressure support. Yeah. And remember that pressure support is additive to the set PEEP level. So if you have a pressure support dialed in of 10 and a set PEEP of 5, your actual pressure support is 15.
It took me forever to figure that out.
It's confusing.
Yeah, it is kind of confusing, but yeah, same with anytime you set a pressure, if you're in pressure control, that's additive to the PEEP as well.
So when would you use? Go ahead.
Oh, I'm sorry. I was just going to say AC versus SIMV. Yes. If your patient is chemically paralyzed or sedated to where they're not triggering the vent, there is no difference in those modes. Absolutely no difference. The only difference between AC and SIMV is if the patient is breathing over the set rate.
So when would you use one over the other?
I use assist control if they're not breathing over the set rate or they're so sedated or paralyzed. Or if they're adequately sedated and paralyzed, I'll just use AC. I'll use SIMV if they have a strong respiratory rate over the set rate. Another reason why I would use AC over SIMV, I think it's more comfortable for the patient. I have heard from intubated patients before that because AC is it's more of a support, you get more support from that mode. So the patients don't have to work as hard. If you are in SIMV with pressure support, the pressure support does help overcome EP tube resistance on those supported breaths, but the patient still has to work a little bit harder. So if I see my patient looking like they're pulling, that they're not comfortable, I might go to AC just for more support.
Okay.
Gotcha.
Cool.
So Kari, would you mind if we go through just a really quick scenario with you? And then we can put the patient on volume mode, and then we'll put that exact same patient on pressure mode so we can see what the difference is between those two.
Absolutely.
Do you have a preference, volume or pressure? I mean, probably for pediatrics, but just let's say normal old adult patient.
I always start in volume, typically, unless it is a small pediatric patient, maybe less than 10 kilos, I'll go straight to pressure.
Uh-huh.
But I start in volume and then see what kind of exhale tidal volumes I'm getting. I'll see what my PEEP flats are. If I can keep it under my PEEP flats under 30 and get good exhale tidal volumes with adequate sats, I'll stay in volume. But if I have any lung issues where it's more difficult to ventilate or oxygenate, I will go right to pressure.
Okay. Well, let's do something super easy. Let's do, what's our main patient? What's the patient you take the most besides ARDS? Because that's not easy. How about just a regular old trauma patient?
Okay.
Let's say 30-year-old motorcycle crash, head injury. So we're intubating for the head injury, for ultra-Del OC. Okay.
So I would put this patient on assist control because we are going to be giving this, if the patient can tolerate, we're going to make him very comfortable with pain and sedation. I would do assist control. I would start at a tidal volume of about 7 mils per kilo, look at my exhale tidal volumes, assess his peak inspiratory pressures and his plats and make sure they stay under 30. If they're over 30, then I would decrease my volume further. And then I would set my respiratory rate to about 14 to 16 and look at my entitled CO2. How old is this patient?
Perfect. Let's say 30 years old.
30. Okay. So this is a patient I would not suspect to have any lung injury, right?
Right.
So again, I would suspect I should have low P-plat, low oxygen needs, although I think I would put them on 100% because per ATLS guidelines, any fresh trauma patient, they need 100% because of any internal bleeding. So but I would start with a PEEP of 5. So I'd do AC, volume control, tidal volume of 7 per kilo, ideal body weight. I'd just quickly, estimate how tall he is and then throw something on there. It does not have to be exact as long as you're in the ballpark. Look at his P-plat, PEEP of 5, 100%.
Perfect. So let's go through that real quick. So I'm looking at, when you're looking at your vent, you get the PIPs, right?
Mm-hmm.
Up at the top,
yeah.
Which is the amount of pressure that's exerted on the entire system. Everything, the lungs, the trachea, everything, right?
It's actually, so PIP is directly proportional to the resistance in the lungs. And it's the resistance in the upper airway.
Yes.
So the large airways and up, right?
Yep.
So large airways, ET tube. So when you think of PIP, always think resistance. Yep. So the patient could be biting the tube, coughing against the tube. They'll have high PIPs if it's too small of an ET tube as well, as well as bronchoconstriction, secretions, anything, blood, any of that in the airway.
And the P-plat, you're measuring the pressure exerted on in a very simple way, the pressure exerted on the alveoli, so the lower airway.
Absolutely, where the magic happens, right? Mm-hmm. So that P-plat is directly proportional to compliance. So PIP equals resistance, P-plat equals compliance. So, and that's really the number that matters. Mm-hmm. You can have high PIPs. You want to make sure you know why your patient has the high PIPs and try to fix that. But that's not what is going to injure the lungs. What will injure the lungs is if we don't keep the P-plat 30 or less, or we can go up to 35 or less in obese patients, just because the weight of the chest.
Right.
Okay. So, Kari, question for you. When you're looking at your pressures and you've got a high PIP and a normal P-plat, and you have like a difference between those two, that's one of those things that indicates increased airway resistance, correct?
Yeah, very good point. That's a really good thing to look at because then you can kind of decide where the issue is.
Right. Yeah,
if you have a PIP of 40 and a P-plat of 18, that directly tells me my problem is upper airway.
Mm-hmm.
So it could be a kinked tube. It could be asthma. Maybe you need to give a neb.
Absolutely.
It could be a lot of different things.
Secretion. Yeah, or maybe the patient needs to be suction or is biting on the ET tube. So it really clues you into where the problem is.
That's cool.
Good question, Steve. Thanks.
The peanut gallery is showing up today.
So, I love it. And then, conversely, if you have a high PIP, say of 40 and a P-plat 35, then, the problem is compliance, right? Mm-hmm. So, that's when you think, then you've got fluid down there. So that could be pulmonary edema. This could be an ARDS patient. It could be from, direct chest trauma, if, for our patient here, if he had any chest trauma.
And measuring a good P-plat, your patient needs to not be breathing. They need to be very well sedated, correct?
Good question. You cannot get an adequate P-plat unless the patient is not triggering the vent. So they cannot have any spontaneous respirations. Yeah, correct.
If y'all are out there measuring your P-plat and it's higher than your PIP, you got a problem. You did it wrong.
Right, done messed something up.
It can't happen.
It's impossible.
So
physiologically, it can't happen.
So let's just run through Kari's algorithm. You have a patient who has high P-plats. I know we've gone through this before, but I just want you to say it again. What is your algorithm of getting that down? What do you do first?
So the number one thing I do is decrease my tidal volume.
Okay. But not below 6.
Not below 6 unless it's ours.
Okay. All right. So you've decreased it. It's still up there. What do you do?
That's when I'm going to accept higher CO2s.
Okay.
Because really, if it's not ours and we decrease it below 6, all we're going to do is further have a further incidence for lung injury, right? So that's why we need to keep it between 6 and 8 mils per kilo ideal body weight. So that's, then you're just going to have to accept higher CO2s if that's the case.
Right. So keep your tidal volume within normal range and stop chasing the number.
Right. And Dan, I think this is the kind of patient, if I went down to 6 mils per kilo, I would try pressure ventilation if I was in volume and see if I could get that P plat lower. So I could get hopefully adequate tidal volumes at a lower P plat.
Perfect. Okay. That's all I need to know.
So let's talk about pressure. Let's say we have the same healthy lung patient and you decide to put him on pressure instead of volume. What does that look like?
Yeah, that's good. One thing that's nice, if you start out in volume and you do get a P plat, that's a really good place to start with your pressure control ventilation. So if this trauma patient that we had, I put him in volume, let's say he had a tidal volume of 450, and I did a P plat and his P plat was 18. That's where I would start if I were to go to pressure ventilation.
All right, so
now
take us through your setup.
Okay, then I would start to, again, pressure ventilation is additive to the set PEEP level. So I would set my peak inspiratory pressure for 13 with a PEEP of 5 for a total pressure level of 18. Mm-hmm. So then the number one thing I want to check, I'm going to look at them. If I can, assess chest size, my entitled CO2, but I want to look at my exhaled tidal volumes to make sure those stay between 6 and 8 mils per kilo. If they're too low, I'm going to up my pressure.
And
how high can I go?
What do you mean by that? What button do you push to increase your pressure?
Well, you're going to increase your peak inspiratory pressure.
Awesome.
So I was at 13 before, so maybe I'd go up to 15. So again, because it's additive to my set PEEP, which is 5, now I'm at a pressure of 20.
So quick question, just for my head. So you went up to 18, is that what you said?
15.
15?
Yeah, from
and then
13.
You have the 5. But let's say you have to increase the PEEP as well. Let's say they're not oxygenating well. You want to increase that to 8. So now you're at 23? Just so I have this.
That
is correct?
That's correct.
Yes.
5 stars.
I'm just going to let you all know. He did it without a calculator.
Thank you so much.
Very nice. Very nice.
So,
all right, so back to pressure. So we just increased our pressure. So interestingly, I don't know why. Kari, you told me this. When your patient is in volume mode, you're looking at the pressures. When they're in pressure mode, you have to look at the volumes. And
correct.
That was like this huge light bulb came on in my head. And I was like, oh yeah, that's how we do it. So what you're saying is you put in your pressure and now you're looking at your exhaled tidal volume to see where you're at. Is it too low or is it too high? So,
exactly, because that's the variable, right? When we, give somebody a certain pressure, that's the only thing we have to monitor. That's the variable we have to monitor to see if that's enough pressure. And if it's too low, you increase your pressure. If it's too high, you decrease your pressure. So you can go either way with that.
And by increasing your pressure, and I just have to say this again because people ask me this question a lot, you're increasing your PIP. That's the number that you're looking for.
That is exactly right. You're increasing your peak inspiratory pressure because that is what you set in pressure control.
Now, let's say I've increased my pressure. We started out at 8. Is that what we said?
Who, me?
I'm just asking Kari, what did we start out with on this scenario?
I thought we started out at 18.
18. So
18 total.
18 total,
okay.
Right?
Right.
So we went up by 2 on our PIP, and then maybe we went up another 2 on our PIP, how far away do you want to get from your PEEP with your PIP? Does that make sense? What's that gradient there?
Makes a lot of sense. You want to stay at least 5 to 6 above your PEEP. Otherwise, you won't provide any ventilation.
Otherwise,
it's just like with CPAP. Yeah, exactly. So you have to have a depth of at least 5 to 6. Otherwise, you're not going to provide any ventilation. And as far as increasing your PIP, this is why pressure is such a cool mode, because it's very protective. We can increase our peak inspiratory pressure to 30 or 35 for obese patients. And that is really our limit, because we can't check a P-plat in pressure control on the Revel or the LTV. That is essentially our P-plat. Mm-hmm. So in pressure control, our PIP equals our P-plat.
Okay.
There's so much you're saying, and I'm just, okay, hang on.
Yeah.
And then I'm going back in my head looking at the...
Okay.
No, this is great.
So in pressure
only
control...
because...
Say that one more time.
Okay, so because we can't directly measure the P-plat in pressure control, we know that the P-plat can never be higher than the peak inspiratory pressure. So when we're in pressure, we know that our P-plat is whatever we set the pressure or lower. So that's why it's protective. So if we limit out at 30, we are still providing lung protective ventilation.
If your PIP is at 30, you know your P-plat is less than 30.
Right.
Absolutely. Okay. Yes, that's correct.
So Holly, you touched on the PEEP differential, and I want to know if that's a term. Does that even exist? And if it doesn't,
we should make one
up. We should make one up.
Yes, it does exist. And what it's called is it's called driving pressure. So in pressure control, the difference between the PIP and the PEEP is the driving pressure. In volume control, the difference between the P-plat and the PEEP is the driving pressure.
So, quick question before you totally lose me. So driving pressure, what, if you could paint a picture for me with just stick figures, what
basically
would
it's
that look like?
How much PEEP is in your alveoli minus how much pressure.
Yeah, it's just the difference between the pressure and the PEEP. That's all. The inspiratory pressure and the PEEP. So difference between inspiratory pressure and expiratory pressure.
Okay.
So, and is the number less than 13 now, or is it 13 to 15?
Actually, there's studies that there's decreased mortality, decreased ventilator-induced lung injury if you keep that number below 14. It's kind of a weird number.
The driving pressure.
Yeah, the driving pressure. And again, in pressure control mode, that would equal your set peak inspiratory pressure minus your PEEP. Or in volume control, that would equal your P-plat, right? Because that's the number that really matters, minus your PEEP.
And Holly, you said 13 to 14? That's
She's less than 14.
Less than 14 is good.
So basically, you're trying to figure out the relationship between how much pressure you're exerting on the alveoli and how much PEEP you have.
Right.
And if that number is higher, then you need to change more. And so I think what it does is it changes the relationship of what you're thinking of is, well, my PEEP can actually go quite a bit higher and our driving pressure is still below 14.
That's exactly right. Because how many times have we had patients on 100% and a PEEP of 5? Right? Oh, honestly, that really shouldn't ever happen, because either you need to come down on your FiO2 or you need to go up on your PEEP.
Man,
I mean, honestly, Kari, and maybe this isn't true, but for us in this transport environment, driving pressure might not be on the top of our list to watch for, because I know that in the ICU with these ARDS patients or people that are really sick, driving pressure is becoming the thing to look at because you can have higher PEEPs.
But like on the interfacilities.
And higher P-plats. Shouldn't
we be thinking about that, especially the longer transports?
We could be. I just, Kari, what's your opinion on that? Like, we're not respiratory therapists. We're not actually changing any sort of therapy in an hour or less.
Absolutely. I mean, we're not going to fix these patients in our, 30-minute transports. And that's really, we just have to get them, maintain them or try to get them a little better than they were. But we're definitely not going to fix them. I think as many tools as we have, we need to just think about things that, the ways we can provide these vent settings that are going to decrease any lung injury. So I think it's good to think about, the driving pressure. I don't know. Do you guys think that's too much?
I don't think so. I mean, it's part of our critical care toolbox, right? Even though I might take note of the driving pressure, wow, it's 14, or wow, it's only 7. So we can go way up on our PEEP, or maybe we can go up more on our tidal volume.
Right. Because the whole idea behind the driving pressure idea and to keep it lower, earlier I talked about that cyclical opening and closing, right? And so when you keep that driving pressure lower, you don't open and close the lungs as much, right? It's just a softer, gentler, it's not this huge open and close. Does that make sense?
Yeah.
Okay, so
sorry.
No.
So think about PEEP as just the stent open, right? So it's going to open and it's going to close a specific amount.
Like the doorstop.
So if you
like the door stopper.
Yeah, if you
right. But
if you have a PEEP
sorry, go ahead.
If you have a PEEP of 5 and an inspiratory pressure of 35, right? That's a huge opening and closing, right? Correct. But if you have a PEEP of 5 and a peak inspiratory pressure of 20, that's a lot less opening and closing, right? So it's less injurious to the lung.
Okay.
And that's the relationship that you're looking for in the driving pressure, is how much they're moving out and in, I guess.
Which is why you don't want a large difference between the two of them.
Right.
Yeah.
Got it.
Yeah.
Oh, Kari.
Right. Right.
Light bulb.
Which kind of brings me back to that point where you have a patient on, and I see this a lot, on 100% and a PEEP of 5, something needs to give there, right? If they really don't need 100%, right, then wean that down, right?
Right.
Or increase that PEEP if they really are having oxygenation problems.
And when you're talking about this specific, like the PF ratio, what numbers are we looking for?
So PF ratio, so per ARDS, the latest ARDS guidelines is under 300 is mild lung injury. 200 to 300, I believe, is moderate lung injury. And under 100 is severe. I know 300 is mild, 200 is moderate, and then 100 or under is severe.
Gotcha.
So the lower the number, the worse it is.
So basically, you want to make sure your SpO2 and your PEEP are a little bit closer than 100% and 5.
Gotcha.
Yeah, absolutely.
Yes.
Yeah. Those are the patients, anytime you have a high PF ratio, you can walk in. And if my patient's on 100% and their stats are 80, I know their PF is going to be, and you can do that without, there's a bleep. And you don't need a blood gas to figure that out, right? If their stats are 80, you know that their PaO2 is not going to be good. So that's automatically going to be a patient where I'm going to think, I need more PEEP, right? To stent those lungs open more.
Okay, so PF ratio, what does that stand for?
Well, she was talking about when you walk in and the patient's on 100% oxygen,
right?
But their stats are 100%.
Right. Why are we doing that?
Why are we doing this, right? Okay. And their PEEP's at 5. Why are we doing this part? We need to wean. Like Kari always says, be a wiener.
Be a wiener. Yes. Be a wiener. Not everybody needs 100% FiO2, right? Or stats of 100, right? We don't need that. We just need stats of greater than 94. There's some patients that we tolerate less or lower stats. So like COPD patients, like 88 to 92, those are just fine. But most patients do just fine with stats of 94 and higher.
So Kari, that's all good stuff. Now, what about that obstructive patient? That patient that is just, their lungs are already full of air that can't get out, that's trapped in there. What would you change up for your ventilation strategy?
So the number one thing about these obstructive patients is they need time to exhale. So that is all I'm thinking. I'm thinking low respiratory rate, like possibly 10 or even lower, depending on how severe the obstruction is.
And then Kari, do you have a go-to with your IE ratio?
Yeah, I like to aim for at least 1-4 or 1-5.
So question on that.
Sometimes,
I listened to a podcast the other day regarding this type of stuff, and they were saying sometimes it's an inspiratory problem as well, and they might choose a 1-1 just so they have that slow inspiration, which matches their exhalation. What are your thoughts on that, or is that even something that's doable?
You know, I haven't heard that. What you can do, because what a lot of these obstructive patients have is a really strong air hunger. So they like a very quick I time, which means a lot of flow at the beginning of the breath because they can't get it out.
Okay.
So they really require increased flow. So what you can do is decrease the I time, which is inversely proportional to the flow, which in turn will give them a higher flow rate, which hopefully will satisfy their air hunger needs.
And so it's a quicker flow, a quicker I time?
Exactly.
Okay.
Exactly. Yeah, the lower the I time, so if you went from 1 second to 0.8 seconds, that flow is going to be delivered quicker.
Okay. What does that damage the airways at all?
No, not at all.
Okay.
Not at all. Well, there actually is an I time button.
Do tell.
Yeah. And so it usually defaults to, if you're in an adult mode, it'll default to 1 second.
Mm-hmm.
So again, that is inversely proportional to the flow rate. If you're in volume control, that flow rate is always constant. So it's a square waveform. So it delivers that flow constantly over the set tidal volume that you have. If you're in pressure control, it's a decelerating waveform. So the I time in pressure control determines how fast it's going to deliver the set pressure. And the flow is variable. So the patient can pull as much or as little flow as they need, which is why pressure control can be more comfortable for some patients because they can control the flow. Whereas volume control, they don't. It is just a set flow dependent on what you set for your I time.
Okay.
Awesome.
All right, so let's go to a scenario. Let's say you're doing in-facility and it's a 74-year-old COPD patient was brought in, was given, beta agonists, all the good stuff, steroids. Patient just starts to tire, so the doctor wants to intubate. Doctor intubates. What settings would you want to see on that patient?
Right. Good. I think it's always important. We never want to have to intubate these kind of patients, but sometimes they fail because they can't keep up that high respiratory rate, right? Because of their distress and they go with failure. But for these patients that get intubated, number one, keep them at a tidal volume 6 to 8 mils per kilo ideal body weight and a low respiratory rate. I start anywhere from 10 to 12. Make sure I have enough time to exhale. PEEP of 5, I don't go any higher than that. Usually these patients are very easy to oxygenate. It's just the ventilation part that you have to get, just have to support them on.
All right. So what if their end tidal is 76?
Great. I don't have any problem with that. And these are patients where you do not want to get them down to normal CO2 levels. You don't want to get them into 35 to 45 range. Why? Because if this patient is chronic, which usually COPD is chronic, they don't live at that range, right? So it's very hard for them to, once they do try to wean off the vent, they won't be able to do it because you have blown their CO2 down so low, and not in their normal range. So just the big thing that I always suggest is to get the CO2 going in the right direction is to slowly lower it. I'm perfectly happy with CO2s in the 50s and even 60s, as long as I'm going the right way.
And so we should not be chasing that number.
Do not chase the number. The biggest thing is to always make sure you have enough time to exhale. That's the biggest thing. And it's interesting, even though you have lower rates, you can blow off more CO2 because you have more time to blow off the CO2 versus increasing the respiratory rate. I think some people walk in, they might see a COPD patient that's just been intubated and they're entitled as 90. So the first thought is, I need to increase my respiratory rate to blow off CO2, which is perfectly normal for non-obstructive patients. But for obstructive patients, completely different, right? You need to lower that respiratory rate, provide much more time, double the time to exhale.
So what does your I to E ratio look like on this type of patient?
At least 1 to 4, 1 to 5, 1 to 6.
Okay.
And these are patients that need a ton of sedation and pain meds, a ton, because they are not used to breathing this slow. They never breathe this slow. But in order to make sure that they don't trap more air, we have to ventilate them like that until they can get strong enough to wean off.
Would you ever pull the ET tube off and press in on the chest?
Absolutely. And that is it's a great point. Anybody that is an obstructive patient or anybody that you ventilate with high respiratory rates, so metabolic acidosis, those kind of patients, ARDS patients, if you suspect auto PEEP to the point where you suspect maybe a tension, you have hypotension, tachycardia, high peak pressures, high plateau pressures, the first thing you should do, pop that patient off the vent, press down on the chest, and just give them time to exhale. If it is auto PEEP, if that's the culprit, your vital signs will quickly improve. Your blood pressure will go up, heart rate will come down, stats will go up. And then then you'll know that was the culprit.
Okay.
That it was just maybe the breath rate was too high. So then when you put them back on the vent, you have to change the settings, right?
Right.
You either have to, number one, lower the rate, or you can lower the volume too. Because the less volume in the chest means less to exhale.
Mm-hmm.
Okay, so a couple of things that I think we all have issues with is maybe troubleshooting the vent. What are some things that you see, and what could we do if I don't know, just run through some scenarios on troubleshooting, like tube dislodgement, or maybe we have low pressures. What kind of stuff would you look for low airway pressures?
Yeah, so low airway pressures, 99.9% it's a leak somewhere in the system. So I start either at the patient or at the ventilator and then go through all of the tubing and just make sure that everything is connected, something isn't loose, and just start from one end to the other. And then if everything looks good, everything's tight, connected, I think about the ET tube. Sometimes that the cuff will lose volume, especially while transporting. So you can check your cuff pressure. Another quick way to do it is if you're in volume, if you're in volume control, look at the difference between your tidal volume and your exhale tidal volume. So if there's a large discrepancy, maybe you're losing a lot because the cuff has lost a lot of pressure.
Maybe you're not deep enough. Would that be, you're losing?
Yeah, that could definitely be an issue as well.
Do you have a mnemonic that you go through?
I just go through the DOPE mnemonic, right?
What's that?
Yeah. And actually it's DOPE. It's plural.
Oh, DOPE.
It's plural. Yes.
And that S is important.
The S is very important, especially with this last patient. So D, displacement, which is always an issue for us, right? So, take a quick look, make sure that ET tube is where it was when you left. Obstruction, put something down the ET tube, make sure it's not secretions. That's one of the easiest things that's overlooked, is just make sure that tube is patent. And then P, pneumo, right? So again, assess for high pips, high flats, high pressures on the vent, low sat, tension, physiology, all that kind of stuff. And then equipment. If you have any issues, if the vent isn't working right, take them off and bag them. A lot of times you can feel a lot with, compliance resistance. But if you can bag them, you should be able to put them on the vent, obviously, unless there's something wrong with the vent. Or we can just blame it on the vent, right? That always works. Right?
Yes.
And then the last one is S for stacked breath. That's the most important. So these are for our obstructive patients or anybody that we're ventilating with high respiratory rates. So you just have to make sure there's enough time to exhale, right? So take the patient off. If their vital signs improve and stats improve after you take them off, that was probably the culprit, was auto PEEP.
Mm-hmm.
Wow.
That's awesome.
That is great.
Sometimes you can get those stacked breaths if there's a lot of vibration in the helicopter and it's that the tube is up against, or the circuit's up against the metal part of the airframe.
Oh, yeah.
Yeah.
It'll trigger a breath.
Right.
So make sure that or if there's secretions inside the circuit, sometimes it'll trigger a breath with that vibration. So
yeah. What can you do to mitigate that?
move it.
Sensitivity. It's too obvious.
Increase your
Yes, move it. Or you can increase your sensitivity, right?
Yeah.
So the higher the number, the harder it is for the patient to trigger a breath. The lower the number, so like 2 or 1, the easier it is for the patient to trigger a breath, and the easier it is for the vent to auto cycle. Mm-hmm. So you can take that number up 1 or 2, which is measured in liters per minute because it's a flow rate that the patients have to trigger to get a breath. So if you increase that just a little bit, sometimes that's enough to for the vent to not be as sensitive to a lot of turbulence or vibration. But you just have to watch that you don't go too high, because if it's too high, then if the patient is taking spontaneous breaths, it can be very hard for them to do that. But it's easy to notice because they do not look comfortable.
Would you ever, if you have an issue, would you ever look inside the mouth and make sure you haven't dislodged the tube, or make sure that everything's good down there?
I don't think that's a bad idea. I think I'd look at my entitled CO2, which tells us a wealth of information. If I had a good waveform that's coming back to baseline, I think I would, it doesn't really show us if we're high or right main stem, but it does show us that we are in
the proper place.
in the right place, right?
Excellent.
But you could do that, but just remember, anytime you look inside the mouth, are you talking about like with a laryngoscope?
Yeah, just to make sure, like if you're getting low pressures and you don't know if it's dislodged, and it's, just as a rule out.
Yeah. After you maybe check your cuff pressure and rule that was okay, you could do that, but just make sure you have adequate sedation, pain meds before you go in there. Possibly even you might need to paralyze just to decrease any adverse reactions from laryngoscopy.
Okay. Do you ever get alarm fatigue? That alarm fatigue, because I know I do, and I know that's horrible, because every time that alarm goes off, we should be making sure that everything's golden.
Yeah, and I think the biggest culprit for that is the high pressure alarm, right? Because that always goes off, and I think we all just press alarm silence and keep pressing alarm silence because it is annoying. You just want it to go away, but really, you can press the alarm silence right away, but you really need to figure out why the high peak pressure alarm is going off, which most of the time it's probably lack of pain and sedation management. But also I think the most overlooked thing is suctioning. When a patient's intubated, and especially with the movement that we put this patient through for transport, that increases the propensity for more and more secretions. So it's a super easy fix. It will do wonders for your ventilation and oxygenation if you don't have all those secretions down there.
Right.
And it could be the big difference from your patient tolerating the transport for just a quick, simple suction. So again, if you have high peak pressures and low P plat, that means it's all upper airway. So think about suctioning.
Kari, that's a lot of great information. I know I learned a lot.
Yeah, me too.
It's great stuff.
Could you just kind of do a recap of what you really think is important, what we really should take home?
Sure. I think it's important with every ventilator patient that we always use lung protective settings, which is a tidal volume of 6 to 8 mils per kilo, ideal body weight. For respiratory rate, set it per disease process. And PEEP levels, again, set that for disease process too. Again, a minimum of 5 for everybody, and a minimum of 10 if you are obese, just due to the chest, the weight of the chest wall, and titrate your FiO2 per disease process. Again, obstructive patients, slow rate. Everybody else, such as metabolic acidosis patients, your DKA, lactic acidosis, aspirin overdoses, make sure that you realize those patients have to maintain a higher respiratory rate to decrease incidence of further acidosis.
Awesome.
Perfect. Of course, pain and sedation.
Yes, pain and sedation. You know what I've been doing lately is setting my timer on my watch. You know, depending on what you're giving, if you're giving Ativan every 45 minutes or you're doing ketamine Q10 or whatever it is, that time goes by really fast. And suddenly you're like, oh no, I forgot to give more pain and sedation. So I've been setting the alarm on my watch. And sometimes when my alarm goes off, I've already forgotten why I set my alarm. And so it's, you know, I think I'm really good at pain and sedation and I really want to be, but it's good to have those little subtle reminders that it's time now. Someone should be maybe keeping time of when you've given your last fentanyl or whatever you're giving, whatever your cocktail is that you like to give.
Right.
Absolutely.
You do not want to have your first time with that ventilator with someone who's super critical, a dying baby, because you're stressed out. You've lost all your thought process at that. So you have to drill. You have to keep up on it. It changes all the time. So this is your responsibility as a care provider to keep up on this stuff.
Mm-hmm.
It is. Yeah, that's a good point. I think if you are not used to pressure control, which I don't think most of us are, I think most of us are used to volume, which is totally fine. But my suggestion is next time you have a very stable patient, intubated patient in volume control, put them in pressure control during the flight just to get used to switching between the two, just so it'll increase your comfort level.
Absolutely. That's a great point.
Yes.
Well, guys, this is a good one.
This is
Yeah,
awesome.
there was a lot of
learned
info.
something.
I hope everybody,
brain go nuts.
I hope everybody enjoyed it.
Yeah, it's great stuff. All right. Well, Kari, thank you so much for just an awesome podcast. Really enjoyed having you on. And I think I learned way more than the vent classes I've got at our department have ever taught me.
Kari's
and
awesome.
I feel like I'm going to have a lot of one-liners or questions to throw at our vent guys that are on our SME team. So right on. Thank you. I just want to say thank you for your time and your expertise. It's awesome stuff.
My pleasure.